return of them after surgical insult. And it is central to the development of complications. That's something that we've learned more and more about in the last 10 years or so. And perhaps more importantly is that it's affected by many of the perioperative treatments that we can choose to give or not to choose to give. So insulin resistance is really a key to the understanding and the enhancement of the recovery of the patient. So insulin resistance is the key to complications and recovery. And let's see how stress, insulin resistance, and glucose interact. Well, this is a typical picture from a textbook showing that at a time of injury there will be a massive release of stress hormones and cytokines that will cause major changes in body metabolism. We're not going to go into details of that, but it's sufficient to say that all of the things that are ongoing in the body as far as metabolism can be influenced by insulin and is a part of that insulin resistance. So how do I define insulin resistance post-operatively? Well, it's below the normal metabolic effect of insulin on glucose uptake and the reduction that insulin normally has on glucose production. So it's a below normal regulation of glucose metabolism. But it's also below its impact on lipolysis and protein breakdown and protein balance. So again, it affects all parts of the body. So if we just look at how hyperglycemia develops, and just take you through a very simple situation post-operatively. We have the hyperglycemia because insulin sensitivity has been reduced. And the hyperglycemia is there because we have increased glucose production and a reduction in glucose uptake in insulin-sensitive tissues, mostly muscle. And that is because we're not able anymore to activate specific translocating proteins, and we're not able to store glycogen information. What we surgeons tend to forget is that this is almost identical to what we're seeing in type 2 diabetic patients. The difference is that our endocrine colleagues will treat that insulin resistance, whereas we don't. But we can do something about it, and that's what we're going to be talking about. This is just some studies that we did with some of our colleagues at the Karolinska, showing that it's actually very complex what is going on in these cells. This is from what is happening in fat cells, where we have reduction in some of the endocrine signaling, very importantly, increase of the inflammatory signaling pathways, and as expected, we know this, reduction in the insulin signaling for glucose uptake. Just to give you a glimpse of where we're going in our insights of what is happening, I show you that picture. So stress is really causing insulin resistance, and that's behind hyperglycemia. So let's go and look a little bit more closely into how insulin and glucose affects recovery after surgery and complications. And to do that, let's make it a little bit more simplistic to begin with. This is a very schematic picture showing that some parts of our body are insulin sensitive and glucose uptake is regulated by insulin, whereas other parts of our cells in the body are taking up glucose mainly by the glucose concentration. And it's important to know this because this is behind some of the problems that we're facing, and it helps us explain what is going on. So normally after a meal, we would have an increase in glucose, as illustrated by the larger letters here. And of course, insulin is released and is very active in pushing the glucose into muscle and fat, but also into the liver. We also have a slightly transient increase into these cells because of the slight and transient elevation of glucose. Now in stress, we may have very high glucose levels. And at the same time, because of the stress hormones, we release even more glucose from the liver. In this situation, insulin is not active anymore, so we're not taking up anything in the muscle or the fat, or very little. And much more is being diverted into those other cells that really don't have any way to protect themselves from glucose uptake. So keep in mind it's kidneys, blood cells, and endothelial and neural cells. Now the other thing that is important to know in this situation is that if we would infuse insulin and just give enough to push down that glucose, as they did very nicely in this Italian study a long time ago now. They normalized glucose levels post-operatively while feeding the patient. They needed to give them a lot more insulin than they did pre-operatively in these patients. But the nice thing was that once they got the glucose down, they also normalized free fatty acid levels, urea excretion, and substrate utilization as an indicator that they actually normalized most of the body metabolism. So insulin resistance, again, showing to be a key to regulate metabolism. So, coming back to my cartoon again, we have a situation where there's too little at this end to some of these organs over here, and too much glucose to some of these other organs. And let's see what that does to where we are. Well, we start with muscle. We all know that patients have a difficulty in mobilizing themselves post-operatively, and they're tired, fatigued, and so forth. Well, we know that with this kind of situation, there's reduced glucose uptake, reduced glycogen storage, so the energy is going down. And at the same time, protein catabolism in these muscles. So energy supply is down. We measure lean body mass in these patients post-operatively. It's also coming down. We measure muscle function. We know that that's coming down. And of course, it's more difficult to mobilize the patient. It really isn't all that complicated. It can be much more complicated once we go into the details. But really, from a clinical point of view, this is really where we need to go. So, for the slow recovery, muscle weakness, it's the muscle, of course, that is the target tissue. So let's go and look at complications. There's a beautiful study that came out from Canada a couple of years ago, where they looked at, they actually did a heroic study of almost 300 patients undergoing surgery, measured insulin sensitivity on the operating table. So you knew how sensitive these patients were when they left the operation. And what they found was, regardless if you were diabetic or not, the degree of insulin resistance that the patient had leaving the table was clearly associated with the risk of complications post-operatively. So a 50% lower insulin sensitivity going off the operating table increased the risk of complications overall by 5 to 6 times, and a tenfold increase in the risk of infections. Looking at it from a slightly different way, doing it stepwise here, for every decrease in the insulin sensitivity as measured with milligrams of glucose infusion, the risk of death was almost significant here. But look at major complications, severe infections, and minor infections. And in this study, they also did the nice thing of actually controlling for a whole lot of potential confounders. So very clear association. There's another study just looking at glucose levels in itself, peak levels at day 1 after surgery, and cardiac outcome. And if you go high on glucose, cardiac arrest is going to follow at a much higher rate. And myocardial infarction is also closely regulated or involved or affected by glucose levels. So again, remember those tissues that we talked about, blood cells, the immune system, kidneys, and nerve cells. Well, look at the range of complications that we're facing. It's all within those cells. Infections, cardiovascular, renal failure, pulmonary neuropathy. I don't think that's by coincidence. And in fact, if you look at the literature coming out of the diabetic field, they have found what they look like a good explanation. It's the uncontrolled inflow of glucose into these cells. With glucose really nowhere to be stored, there's no glycogen there, so it has to go down to glycolysis, and eventually that will cause production of oxygen-free radicals, which will then affect upstream, trying to protect the cells from these from the production of oxygen-free radicals. They block glycolysis and the Krebs cycle, and they alter eventually gene expression, enhance the inflammatory response, and get a vicious circle. So in a more simplistic way, we can look at it with stress of surgery, release of hormones, cytokines, get that insulin resistance, hyperglycemia, loss production, enhanced inflammation, and then more insulin resistance. So just looking at some more normal patients coming into surgery, these were normal weight and coming in for cancer surgery in Wyoming and then back home. And we looked at HbA1c levels in these patients, knowing that cancer can cause insulin resistance itself. So we would be expecting that some would have a higher level of glucose even preoperatively, even though they were not diabetics. And what we found was that those patients that had preoperatively higher HbA1c also had a higher glucose level throughout their postoperative care period. Only 1 millimole, which is not a whole lot. But when we looked at the rates of complications, again, there was a difference between the two. We really can't distinguish whether that was from the preoperative disturbance in glucose or their postoperative just slight elevation or not. But again, it was the infections that dominated the problems that these patients were facing. Knowing that hypoglycemia impairs immune function is really nothing new. This is from Resistencia many, many years ago, where they were interested in this, and just a summary of what they found was that diabetics with poor glucose control have a number of problems in their immune system, which could all be altered for the better if glucose control was installed again. So now we're going to move into enhanced recovery after surgery, which is really a whole range of different treatments that we all do around the operation, and that all have an impact on the outcome as we read the literature. And that's what we bundled together to put together a protocol of perioperative care. I'm not going to go through all of that today. We're going to spend more time on it tomorrow. But just to illustrate that there are a number of elements that have very pronounced impact on insulin resistance in this bundle of treatments. Preoperatively, we can give carbohydrates before the operation. We can give the epidural, anesthesia, which would block the release of stress hormones. Postoperatively, keep the stress down by good pain control. And we can also feed these patients postoperatively, as we've been talking about. Today I'm going to spend my time on preoperative carbohydrates because that's where I'm coming from myself as a challenger of old traditions. So I'm telling you that we should give patients preoperative carbohydrates instead of having them fasting overnight. And I don't know, but I don't think Mexico has changed their guidelines yet. So I'm going to challenge that right up and down. I'm going to be happy to take any discussion. Now, nothing to eat or drink from midnight to the day of surgery. That is something that I've been asking people all over the world, and everybody knows that you are not allowed to do that. This is probably the best known medical rule throughout the world. But, did you know how this routine actually came about? Well, this was the first general anesthesia in 1846. Amazing breakthrough, obviously. Here you could have these patients be taken through something very painful without even knowing it was happening, without any pain or anything. Sad thing was that 2 years later in Edinburgh, they were going to extract the toenail from a young lady who had just had lunch, and they were using chloroform at that time, and obviously she had problems. She aspirated and died from it, and that's the first anesthesia death in the literature. And these people obviously were very concerned with that situation and said, well, we better make sure the stomach is empty by the time we finish, or we put the patient to sleep. So they said, give it plenty of time, fast from midnight. Actually, Lister challenged that just a few years later and said, you should give these patients some beef tea because they're hungry and they're not feeling well for your afternoon cases. But there were some reports of problems in cesarean sections from Mendelssohn in 1946, but actually none of those patients died from their aspiration. And then somebody just wrote a textbook in 1964 and stated patients should be fasted from midnight. And that's how every single textbook in anesthesia from then on wrote the same thing. There was never, ever any evidence for this. Never. And we all know, if we have studied just a tiny bit of medicine, that if we drink a bottle of this, it's not going to take 8 hours before we need to go to the bathroom. It's going to take 2 hours maximum. And of course that has passed our stomach. It's simple physiology. The risks of aspiration, which is really very few in elective surgery. The risks associated with concomitant disease. That's where we got to watch out. And we gotta, of course, use our brains a little bit to see that patients who have a slow gastric emptying would need to wait a little bit longer. But this is what the curve for clear fluids look like. It's emptied very, very quickly out of the normal stomach. Whereas solids empty at a different curve and much slower. So solids, yes, take it easy, but liquids, no problem. So why would you start to challenge the LPO routine? Well, it's not a guarantee of an empty stomach anyway. It's the same gastric volume with or without clear fluids. It's been studied over and over again. And it improves well-being, and that's why the whole thing was actually challenged initially by an anesthetist from Canada. Roger Maltby was the one who really started this. So this summarizes what modern fasting guidelines should look like. And if you haven't changed yet in Mexico, I would propose you put it to the scientific board of the Anesthesia Society to come up and have a big session with the whole Mexican Medical Association present to give the knowledge of this and to change those guidelines. Because all they have to do is read the literature. It's very simple. So clear fluids, coffee, tea, and so forth, and some juices without pulp can be recommended 2 hours before anesthesia and surgery. Of course, emergency surgery, different story, and those with slow gastric emptying. And it's there to reduce the discomfort, of course, primarily. There's a Cochrane review to support this. I won't go into that. So why should we then do the carbohydrates and not just to stick to coffee or something that would make the patients feel a little bit better? Well, I started out doing some animal works many years ago, and it showed that there was a survival benefit from fed animals compared to those that were fasted just a short while. And it was all related to glucose metabolism. And I found that it changed the metabolic setting, no surprise. And that made a difference for the stress reaction. And it really is an unnatural way to prepare for stress. So we started looking into this, thinking that it might have some potential metabolic gains initially in man as well. So what do we do if we set the patients before the operation in the fasted state? Well, we have low glucose level, insulin is not active at all, and we're producing glucose from the liver, and there's low uptake after an overnight fast. If we just challenge that and give a carbohydrate feed, we can get that insulin sensitivity up and start to activate all these systems in a positive way, in an anabolic way before the operation. And this actually carries through. The other thing that we had to take care of early on was to make sure that it was safe. And here you see the decay of a carbohydrate drink that's 12.5%. Maltodextrins, you need to have a fairly high percentage to get that insulin response. And it's almost as quick as water, as you can see. And now we've done this in numerous patients. There's a lot of clinical studies. We have the big enhanced recovery database. 3 million patients in Europe and elsewhere have been taking this in surgical practice. No single adverse event has been reported. So I think it's fair to say that this is safe. So why should we then do it? It's safe, but what's the point of doing it? Well, it's been shown to reduce the metabolic stress of surgery, effectively reduce insulin resistance, improve well-being of the patient both pre- and post-operative, and getting that insulin going before the operation improves post-operative muscle function, reduces lean body mass losses, and may even result in faster recovery. Again, just a couple of quick slides to show that there's stuff going on inside the cells. This is in muscle. This is the carbohydrates with a much higher activation of signaling systems to keep that glucose being transported into the cells. And likewise, here's another signal, key signal for the anabolic pathways. Again, much higher post-operatively with just the carbohydrates before the operation. This will help us explain why lean body mass is better preserved, as they showed before the other studies here in Scotland. And if you look at muscle strength, again, a big difference. With the only difference between the two groups, that one group got the carbohydrates before major surgery. And other muscles fare well from this as well. This is the cardiac muscle, the heart, needing less inotropic support with carbohydrates. So it also improves well-being of the patients. That was the main objective for changing the whole concept of fasting anyway. and it's now in all the guidelines all over Europe, and actually in Australia and other places as well. And I'd like to show you our most recent meta-analysis showing that, in fact, in major surgery, it also reduces length of stay as an indicator of faster recovery. So let me summarize that insulin resistance is key to complications and recovery, and mind you, I think it plays a central role, and that stress induces resistance and hyperglycemia. Glucose control, avoiding insulin resistance are key to enhancing the recovery after surgery and avoiding complications. Carbohydrates instead of overnight fasting is a simple way, an example of how we can do that and to improve the outcomes. Just for a moment, consider this. Suppose there were no risks of aspiration. Who would then propose that we would have the patients fasting for 16 to 18 hours before the stress of surgery? So, I'll conclude by saying insulin resistance is important in surgery, key to the understanding of associated complications, and can be modulated by simple means. And tomorrow, we'll talk how we use this information, bundle it up with the other components to show how we can really improve metabolism using metabolic understanding to improve outcomes. And with that, muchas gracias. Thank you.